Good day to everyone. My name is C.B. Mammaril, and on behalf of the Systems for Action National Coordinating Center, I'd like to welcome you all to today's Research and Progress webinar on implementing the New York City Macroscope Electronic Health Record Surveillance System. Before we begin, we'd like to acknowledge the funding and support of the Robert Wood Johnson Foundation. We'd also like to remind everyone that if you have questions about the webinar, that you can type them in the lower left-hand corner of the screen in the chat window, and we'll try to get to your questions at the end of the presentation. So without further ado, it is my pleasure to introduce to you our presenters for today, starting with Dr. Katharine McVeigh, who is Director of Research for the Division of Family and Child Health at the New York City Health Department of Health and Mental Hygiene, and is also Principal Investigator of the New York City Macroscope Chart Review Study. Tina has a master's degree in public health and a doctorate in measurement, evaluation, statistics, both from Columbia University, and has worked on research and surveillance projects in the domains of maternal, infant, and reproductive health, HIV, AIDS, substance abuse, mental health, early childhood development, and educational outcomes, and the use of electronic health records for population health surveillance. Our other presenter is Sharon Perlman, who is Director of Special Projects for the Division of Epidemiology at the New York City Department of Health and Mental Hygiene. Sharon is also co-principal investigator of the New York City Health and Nutrition Examination Survey and a founder of the New York City Macroscope. Sharon has a master's degree in public health from Columbia University, and her research has focused on chronic disease, mental health, health impact, and disease modeling, and the interaction between public health and primary care. So with that, I'd like to turn it over to you, Katharine and Sharon.
Thank you. Good afternoon. Thank you for joining us today. For 4 years, my colleague Sharon Perlman and I have been working closely together, along with numerous colleagues from the New York City Department of Health and Mental Hygiene, the City University of New York School of Public Health, and New York University, to develop, implement, and validate the New York City Macroscope Electronic Health Record Surveillance System. This has been an exhilarating project to work on and a tremendous learning experience. We are delighted to share our experience and findings with you and hope that you will reach out to us as you learn to work with EHR data in your own jurisdictions. Excellent. Before we start, we would like to thank the many members of the New York City Macroscope team, as well as our generous and supportive funders. And now I will turn the presentation over to Sharon Perlman, who will tell you about the New York City Macroscope and present the results of our population-level analysis.
Okay, thank you, Tina, and thank you for having us today to talk a little bit about the NYC Macroscope project. We are very excited to be doing this and to hear your thoughts and questions at the end. So let's start from the beginning. Why is this important? Why are we focusing on data to begin with? And I'm sure many of you think about these issues in your own work. So this is a quotation from one of my favorite quotations, and it's from Jim Barksdale, the former Netscape CEO. And he said, "If we have data, let's look at data. If all we have are our opinions, let's go with mine." So obviously, it's preferable to have good data, just rather than following someone's opinion. The good data allow us to set better policies, have better programmatic decisions. We can use it for advocacy. It enables us to evaluate what we're doing, to stop things that aren't working, to be accountable to our funding sources and to the public at large, and in general to use resources as efficiently as possible. So just some background. Some traditional sources of data include birth and death certificates, notifiable disease reporting, hospitalization records, and surveys, both telephone surveys, in-person surveys, online surveys, and data from other sources. So EHRs are an emerging source of public health data, and EHR use has really grown over the last 10 years, as you can see from this chart. In the blue line on the top, you can see use of any EHR system has increased to about 87% in 2015. And this really represents an opportunity to use EHR data not only for clinical purposes and quality improvement, but potentially for public health surveillance. So we know that traditional surveys and other data sources are very valuable, but surveys in particular are becoming very difficult to conduct. Response rates are decreasing nationally, and examination surveys can be very expensive and labor intensive. And with these and other data sources, it can often be a very long period of time from when the data are collected to when they can be used. So EHR data can complement these existing data systems, and then in some areas there's no source of local data at all, and they can really be extremely valuable. But as with any data source, there are some limitations. So this is the population, of course, that is in care, that sees a provider. And different networks may have different levels of representativeness in terms of patients and providers. Furthermore, if data are aggregated, there may be duplicate records that it's virtually impossible to identify and deduplicate. And then data may be collected and recorded in different ways or in free text and other areas where it's difficult to access. So in this context, a group of us in New York City created the NYC Macroscope, which uses primary care data from a very large EHR network. And we were initially focused on conditions that were important to public health and mainly chronic conditions. And as Tina mentioned, this was a New York City Health Department effort in conjunction with the City University of New York School of Public Health, and our colleagues who were there are now at NYU. So the Primary Care Information Project is here at the Health Department, and we're very lucky that this is a large established EHR network. It covers about 2 million patients as of 2013, about 700 practices. It was started initially to try and get EHRs into high-need areas, and the Health Department subsidized the cost of purchasing the system and provided technical assistance. And gradually it's expanded over the years, and it's become more representative and throughout the city. So you can see some of the providers here, where they're located. And the hub, which is an interactive system which can query the various practices, and then it gets aggregate accounts that come back to the health department. So for example, we can query how many women in a practice 20 to 39 have diabetes, and we'll get a total count for that practice, and then we can add it up over all the practices and get an estimate for the whole group. We did have several inclusion and exclusion criteria. At the practice level, we had quality thresholds that were guided by meaningful use standards. Providers, we sought to include only primary care providers, and for patients, we required a visit in 2013 and age, sex, and zip code recorded in the record, and location in New York City. So we started out with about 1.3 million adult patients when we limited to primary care and we applied our inclusion criteria. We were down to about 716,000 patients, and according to our estimates, this is about 17% of patients who have sought primary care in the last year. This is another map of macroscope coverage throughout the city. You can see the darker shades represent greater penetrance by patient zip code, but we do have patients in all zip codes, and it is fairly well representative of New York City. So when the macroscope data, we weighted to the distribution of the New York City adult population that had seen the healthcare provider in the past year, and we validated it against two well-established surveys. The first was the NYC Health and Nutrition Examination Survey, which is modeled on the national HANES. We go into the field and we ask people a lot of questions about their health, and with their permission, we take blood and urine and do objective testing of diseases. We also measure height, weight, and blood pressure. And you can see that there were about 1,135 people in care in NYC HANES. And then the NYC Community Health Survey is our annual random digit dial telephone survey. And from that, we had about 6,166 people who were in care. So when we were developing our macroscope indicators, the initial group, we were looking at things that were important to public health and chronic disease indicators in particular, and we were interested in better understanding the strengths and limitations of the system we were designing. So we selected the prevalence, treatment, and control of diabetes, hypertension, and cholesterol, as well as the prevalence of obesity, smoking, and depression, influenza vaccination, and then we stratified by sex and the age groups listed there. So here are the definitions for the indicators that we used. I'll kind of just quickly go over this. Obesity, we had measured values from Haynes and Macroscope. From CHS, we had self-report. Smoking, we had structured smoking section from Macroscope, self-reported in the surveys. Hypertension, diabetes, and cholesterol, we had ever diagnosed in Macroscope, self-reported from the surveys. And then we had these augmented definitions for those three, which took advantage of lab results and measured values. And then for depression, we used the PHQ-9 in both Macroscope and Haynes. Influenza vaccination, we had record of vaccination in the medical record or self-report from Haynes. So here's the exciting part, our results. And first, before we did this, we established 5 a priori criteria to determine whether we thought the results were close enough that we could consider using the EHR-based estimates for population health surveillance. So those criteria included statistical equivalence and difference, relative difference, prevalence difference, and then consistency across the 6 age and sex strata. So as you can see, some of the indicators really performed quite well. Others did not. The dark blue is Macroscope, the light blue is Haynes, and the green is the community health survey. Hypertension, obesity, and diabetes diagnoses and smoking prevalence are all fairly similar, but depression and influenza vaccination, Macroscope is quite a bit lower than the surveys. And we suspect that for depression, it's because providers don't routinely screen for depression, and for influenza vaccination, that people often get a vaccine in their workplace or somewhere else, and it doesn't make it back to the EHR. This is a summary of results from the 3 surveys for our major indicators, and then at the bottom there is this summary of results. Here are our a priori criteria, and you can just look across and see the check indicates that it met those criteria, and the X indicates that it did not. So you can see that hypertension, smoking, diabetes, and obesity all perform pretty well, and we recommend using those indicators. Depression and influenza vaccination do not, as I mentioned before. And then hypercholesterolemia is kind of an interesting indicator. It performed fairly well at the population level, but in our chart review study, which Tina will talk about more, it didn't perform well. So we're recommending that that be used with caution. And there was also an issue there that the guidelines for cholesterol treatment changed in 2013. It was no longer based on target numbers and more on risk profiles, so that indicator probably needs some more work in the future. And with that, I will turn it over to Tina, who will talk a little bit more about the chart review study.
Thank you, Sharon. Readjust our seating. Okay. As you just learned, our population-level validation work found that New York City Macroscope prevalence estimates were similar to estimates from gold standard surveys for measures of obesity, smoking, diabetes, hypertension, and hypercholesterolemia. But those results did not tell us whether we had good measures and an unbiased sample, or whether New York City Macroscope produced a lot of false positive and false negative results that canceled each other out. We also did not know whether our results were generalizable to other settings. The question of generalizability is important because the New York City Macroscope is unique in that it draws its data from a network of providers who engage in clinical quality improvement with the health department and who all use the same eClinicalWorks EHR platform. To answer these questions, we carried out a chart review study and quantified the sensitivity and specificity of our New York City Macroscope indicators. And these are the steps that we went through. And I should note that EHRs are not set up to electronically transfer the data from a complete medical record. So we had to print out the copies of the EHR and abstract the data as if we were working with paper files in the first place. As a reminder, if a measure has low sensitivity, it will underestimate prevalence, and if it has low specificity, it will overestimate prevalence. If both are low, you may get a prevalence estimate that is comparable to the gold standard estimate because the errors cancel each other out. And so that is really what we were trying to tease out in this study. For the chart review study, we focused our attention on indicators that had performed well in the population level analysis. We assessed sensitivity and specificity in data from two distinct groups of providers, those who had contributed data to the New York City Macroscope and those who had not. We also looked at the subsample of records from non-macroscope providers who had attested to meaningful use to assess whether to recommend that other jurisdictions include documentation quality criteria aligned with meaningful use in their system design. Additionally, we carried out a second sensitivity analysis to assess whether we were losing important information because New York City Macroscope is not able to capture data from unstructured fields such as free text or scanned PDF files. I won't present those findings here because we found that incorporation of unstructured data had minimal effect on indicator sensitivity. I mention this because previous studies have found the incorporation of unstructured data to be useful, and also because the cost of capturing it can be quite high. This diagram shows how we got to our sample of 190 records, including 48 New York City Macroscope records and 142 non-macroscope records. Of the non-macroscope records, 86 were from providers who had attested to stage 1 meaningful use by the end of 2013. A unique feature of this study is our sample, which was drawn from a population-based survey instead of from a specific practice or healthcare system. In total, we have data from 172 different providers who work out of 123 practices and use more than 20 different EHR vendor platforms. This feature strengthens any conclusions we make about the generalizability of our indicator definitions. Of the 190 New York City Haynes participants for whom we obtained consent and performed a chart review, 48 were from clinical practices contributing to the New York City Macroscope. When we compared New York City Haynes data for these 48 participants with data contained in printed copies of their electronic primary care record, we found moderate to high sensitivity for indicators of obesity, smoking, diabetes, hypertension, and for the augmented indicator definition for hypercholesterolemia, and we found marginally acceptable sensitivity for the hypercholesterolemia diagnosis indicator. Specificity was low for both measures of hypercholesterolemia and high for all other indicators. Now we will turn to the results for the other 142 records to address the generalizability of New York City Macroscope EHR surveillance indicator definitions to data from non-macroscope providers recorded on a variety of EHR vendor platforms. Here we present the sensitivity for the non-macroscope records in gray, the meaningful use subsample in navy, and the New York City Macroscope records in light blue. As we found with the New York City Macroscope records, sensitivity in the non-macroscope records was well above our a priori validity threshold of 0.7 for all indicators other than hypercholesterolemia diagnosis. When records were restricted to those from practices that had achieved stage 1 meaningful use, those that were depicted in the navy bars, The sensitivity of the obesity, hypertension diagnosis, and smoking indicators increased by 5, 10, and 12 points respectively relative to the sensitivity in all non-macroscope records, but sensitivity of other indicators changed less dramatically and in both directions. Here's a streamlined version of the previous slide. Turning to specificity, as we found with New York City Macroscope records, the specificity of non-macroscope records was low for both indicators of hypercholesterolemia and high for all other indicators. Restricting the sample to records from providers who had attested to stage 1 meaningful use had negligible impact. In summary, both indicators of hypercholesterolemia performed poorly. All other measures performed well. There was consistency across New York City Macroscope and non-macroscope records, and restricting records to those from providers who had attested to stage 1 meaningful use improved the sensitivity of obesity, smoking, and hypertension diagnosis indicators. The strengths of the study include the heterogeneity of providers and our innovative sample drawn from a gold standard population-based survey. We were limited, however, by the small sample size and resulting large confidence intervals around our stratified estimates of sensitivity and specificity. In conclusion, New York City Macroscope indicators of obesity, smoking, diabetes, and hypertension prevalence are ready for use by New York City Macroscope and are generalizable to EHR data from other sources. Further work is required to develop valid indicators of hypercholesterolemia, and we recommend incorporating meaningful use criteria into EHR surveillance system design to maximize validity. Now that our primary validation studies have been completed, we've been building on our experience in several ways, including assessment of methods to adjust for bias and missing data, development and testing of approaches for small area estimation, and exploration of the application of New York City Macroscope methods to EHR data from other sources. We have also begun conceptualizing what a New York City Macroscope child module might look like. To learn more about the New York City Macroscope, please take a look at our 4 primary validation study publications, including our recently published commentary in the American Journal of Public Health. You may also be interested in 2 other New York City Macroscope papers that have been or will soon be published in the journal Preventing Chronic Disease. Finally, the generalizability study results that I presented today have been written up, and that manuscript is currently under review. So keep a lookout for that paper over the coming months. Once the generalizability paper is published, we will also release a set of fact sheets that reorganize the presentation of study findings by topic. We hope that this fact sheet format will make it easier for EHR surveillance system developers to incorporate the lessons we have learned into their work. I want to thank you for your attention. Please don't hesitate to contact us to share your experience, request our advice, or to develop future collaborations.
Thank you, Sharon, and thank you, Tina, for your presentation. And now we would like to hear some commentary. So let me first introduce our commentators for today, starting with Dr. Sungwoo Lim, who is Director of Research, Evaluation, and Methodology for the Bureau of Epidemiology Services at the New York City Department of Health and Mental Hygiene. Sungwoo and his team provide analytical support to the Department of Health, Mental Health and Hygiene evaluation projects, and has led an effort to develop and implement innovative methods to improve validity of survey and administrative data via modeling and data matching. Sungwoo has been using the New York City Macroscope chart review study data for a variety of new projects involving EHR estimate calibration, imputation of missing EHR data, and the creation and validation of small area estimates from EHR data. Our other commentator is Jenny Smolen, who is a research and evaluation data analyst for the Primary Care Information Project at the New York City Department of Health and Mental Hygiene. Jenny oversees the use of clinical EHR data queried through the Hub Population Health System to support and evaluate internal programs. Jenny serves as a liaison for collaborations that use Hub data, such as the New York City Macroscope, and applies lessons from the Macroscope to Hub data and analysis processes. So with that, I'd like to turn it over first to you, Sungwoo, for your comments.
Thank you very much. Again, this is Sungwoo Lim. I have joined the Macroscope team at the end of the initial work that Sharon and Tina just presented. My main research focus on the Macroscope project has been to strengthen existing methods, including reviewing inclusion-exclusion criteria, sampling strategy, and missing data. I've been also exploring and developing new methods to improve and advance EHR data as a public health surveillance tool. Today, I would like to showcase one of these efforts, how I have used chart review data to reduce bias in EHR-based estimates. The chart review data connected EHR data with the population representative survey, and this data structure enabled us assess quality of EHR-based estimates. As Tina just presented, using the chart review data, the Macroscope team calculated sensitivity and specificity of EHR-based estimates with the assumption that the survey data can be used as a gold standard. We then use this information further to quantify bias and address it. Here are two examples. The first example was using chart review data to build a calibration model. We built regression models using sensitivity and specificity as outcomes and age, sex, and neighborhood poverty as covariate. It allowed us to calibrate EHR-based estimates and consequentially reduce bias explained by these three covariates. For example, the young adults were more likely to receive influenza vaccinations outside of primary care settings compared with the older adults. This results in discrepancy in prevalence of influenza vaccinations between survey data and EHR data. So the calibration models capture these differences and help us reduce bias in EHR-based prevalence estimates. The second example I want to present today was using the chart review data to build on imputation models. From the chart review data, we estimated propensity to participate in NYC Haynes and EHR. We then built multiple imputation models to predict Haynes estimate for EHR samples per each propensity stratum using age, sex, neighborhood poverty, and EHR prevalence estimate as predictors. We are able to almost completely reduce bias in EHR-based estimate at the expense of increased variance estimate. So as our next steps, we will continue to explore an approach to extract more information from EHR to improve model performance and also explore different methods to reduce bias in EHR-based estimates. So now I'm going to turn it over to Jenny.
Hi everyone, this is Jenny Smolen. I joined the Macroscope team after the conclusion of the initial work that Sharon and Tina presented, so I'm relatively new to the Macroscope team. But as mentioned in my bio, I currently manage the Hub Population Health System, which is the EHR data system that was used for the New York City Macroscope. To give a little more information, the bureau I work in, the Primary Care Information Project, or PCIP, was created to bring actionable information to primary care practices as a way to provide data-driven interventions for health. We use data from the Hub to share back to providers through dashboards, to support and inform our programmatic activities, and to contribute to public health surveillance through the Macroscope and other projects. So the chart review study has been really useful for us because it helps reinforce the high quality of the data that the Hub derives from PCIP practices that use eClinicalWorks. One of the things that we work with our providers on is quality improvement, which includes documentation. So this finding has supported the success of that work since it demonstrates the high sensitivity and specificity of data from the PCIP practices that were included in the macroscope on most measures. This also supports our use of hub data as a valid source that is of sufficient quality to be used for health surveillance, like the macroscope and other projects. This study also demonstrated that PCIP providers may actually have higher data quality on certain measures, particularly hypertension and smoking, which shows the value of the support that we provide to our providers and its public health emphasis, since, for example, we encourage providers to screen for smoking status using the structured data form in their EHR. The conclusions of this study and the macroscope project as a whole have informed data practices that we now routinely apply in analysis of hub data. So, for example, the PCIP completed a chart review of our practices in 2012 that showed how much impact documentation quality has on EHR-derived quality measures, particularly for numerator loss. The macroscope work has helped us create a tool to address this issue and, in a sense, clean our data. We now regularly apply the documentation quality thresholds that Sharon mentioned earlier that were developed by the macroscope team as a criterion for inclusion in our analyses to make sure that we're limiting our analyses to those providers that have sufficient documentation quality to be giving us good data. The results of this study continue to be put into practice at PCIP. It has also been useful for us to see that records from non-PCIP practices, so practices that aren't using eClinicalWorks and aren't contributing data to the hub, have also demonstrated the validity of their data. Since in the future we may expand our data sources at PCIP to include data from other sources, such as health information exchange data, which comes from multiple EHR systems. Thank you all.
Yeah, thank you, Jenny. Thank you, Sungwoo. And so before we open the webinar to questions from the audience, we'd like to give a chance to our presenters to respond to the comments by our commentators. So I'd like to turn it over first back to Tina and Sharon, if you'd like to respond or add something also more to the discussion.
No, I mean, thank you to our discussants. I think they provided good context or elaboration.
Okay. All right. So we'll open now the webinar to questions from the audience. And so we'd like to remind our audience participants that you can type in your questions at the lower left-hand corner of the chat box. I think we have enough time to get to all the questions today. But if we don't, we can always direct those questions to our presenters today, or also via the S4A web center, we can also forward those questions to the New York City Macroscope team. So let's start with a question from Jonathan. So Ann Kelly, just help me forward these questions to the screen as needed. So Jonathan asks, was potential duplication of patient records in macroscope addressed in the data analysis? Is such duplication of concern? So this question is for the whole macroscope team.
Hi, Jonathan. This is Jenny. So the potential duplication of patient records in macroscope is unfortunately not something that we can suss out on our end because, as was mentioned earlier, we only get a number. We get the count of patients with hypertension, or whatever the criteria was for that particular measure. However, we have methods that we incorporated to try and at least limit the impact of such possible duplication. For example, one of the inclusion criteria for the macroscope was that we only took data from primary care providers. And although it is possible for someone to, for example, switch primary care providers and be seen at one practice and then later in the year be seen at a different practice, we figured that the likelihood that someone would see a provider who contributes data to the hub, who is a primary care provider, and then went and saw another primary care provider who also contributes data to the hub in the same year was relatively unlikely. So we weren't so concerned about it, although there is a possibility there.
And we purposely did not include OBGYNs as in our definition of primary care providers because we know that many women see both an internist and a OBGYN.
All right, so we have a couple of questions here from Angela. Let me just start with some of the questions she has. So one question is, do you gather individual level identifiable data? That is, can you follow an individual patient longitudinally?
I'll take that question as well. We do not gather any identifiable individual level data. We send a query out and we get back a number, and that's the extent of what information we have about those patients, that they met the criteria that we queried. So this means, unfortunately, we cannot follow an individual patient longitudinally over time. So the data that we have reflects the year that was queried, 2013, and we can't then re-query those same patients with the current technical system that we have in place for the hub.
All right. So another question is, how did you define hypertension, diabetes, quote unquote, in control? Not sure how that question is.
So,
yeah.
Hypertension control was a systolic less than 140 and diastolic less than 90, and diabetes was an A1C less than 9.
Another question is, how did you determine that use of unstructured data / NLP was not useful? I wonder what NLP means.
Natural language processing.
Okay, sorry about that.
So for the chart abstraction, when we were abstracting the data from the medical records, we abstracted the data from structured fields that were required to create the indicator algorithms. But then we also abstracted a lot of additional data from the charts that came from unstructured fields or places in the chart that we weren't tapping. And we put that data into structured fields within our abstraction tool so that we could then basically create two sets of classifications, one for whether the patient had the condition based on the strict macroscope algorithm, and then a second classification based on whether they had the condition on the macroscope algorithm plus information from these other factors. For example, a note in the record, or a lab result that was scanned but not incorporated in a structured field, that kind of thing. And when we did that, we found that there was very little difference in the classifications of each patient, and it really didn't change sensitivity at all. And so in our situation where, first of all, it's impossible for us to extract that unstructured data, it was reassuring that we weren't missing a lot of information by not being able to do that. For line-listed EHR surveillance systems where they do have individual records and where natural language processing could happen, I think looking at this very closely and doing a cost-benefit analysis would be really important, because at least our data didn't demonstrate that it would be cost-effective, even if we could do it, to do so.
All right. And another question is, I guess, related to that cost-benefit work that you would be thinking of. How was your work, or how was the macroscope project funded, is the question. Is one question from the audience.
This is Sharon. I can take that. And the short answer is with a lot of hard work. And the longer answer is that we have been trying to do a second NYC Haynes for many years. So the first one was in 2004, and we wanted to do another one as a follow-up. And it's a huge undertaking, and it's very expensive. So we were thinking about that and thinking about how to fund that. And then our commissioner at the time, Dr. Tom Farley, came up with the idea of trying to use an NYC Haynes to validate health estimates from electronic health records. And this really was like a perfect opportunity, since we had the resources to do the Haynes if we could get funding, and we had such a great EHR system, so we could do this kind of groundbreaking work. So, kind of in a year-long process, we got a number of funders interested in this idea. There were about 4 or 5 funders who contributed to this, and then additional funders who helped with the chart review. And we collaborated with a lot of different people, and a lot of people here at the health department worked on it. So it was a huge effort, but it's been great to see the results.
So speaking about, some of the next steps that you were talking about, particularly the child module that's in development, is this something that is already being funded, or is it still being planned out or developed? Could you elaborate maybe just a little more about it, or tease a little some of the details or features that you're hoping to include in this child module?
So about halfway through my experience with the macroscope, I moved into the Division of Family and Child Health. And so one of my goals is to try to bring macroscope work into my current arena. And so when we were thinking about what next for the macroscope, what kind of modules do we want to do, what new indicators do we want to address, I've been very keen on having them be child indicators. And so we've been talking about what's the right timing and what would we want to capture. Child obesity, I think, is an area of interest, especially my division is very interested in children under the age of 5. And so getting obesity data on children under 5 at a population level is difficult. So that would be one area. I think asthma is also of very high concern here. I'm also thinking potentially developmental disabilities might be an area of interest, but we haven't really come up with a concrete work plan at this point, and then we'll have to pitch it to funders.
I see. And would it sort of follow the same template, working with the PCIP network or project that you followed, just looking now at, of course, at child patients? Would that be sort of the model to follow?
Of course.
Yes.
Okay.
Yes. Yeah,
and I guess
part of it is validation, trying to figure out, if we want to expand to modules where we don't have population-based survey data for validation, what other data sources might we have that we could use for that purpose?
Excellent. So I think we can end with one last question. You alluded to those fact sheets that you're waiting to release pending the publication that's under review, the article that's under review. Could you describe in more detail and how you hope they will be used? I mean, once you do release them.
Sure. So as I put up on the slide, we have 3 publications in eGEMS that describe in painstaking detail first the methodology and then the results for the behavioral indicators, the smoking, obesity, depression, and flu is in one, and then the metabolic conditions, prevalence, treatment, and control of hypertension, diabetes, and hypercholesterolemia is in a second paper. And those findings include, the data and charts and so forth. And then the generalizability paper provides, the data that I just presented, but in more detail. And so what a fact sheet does is it takes the data from those 3 papers or 4 papers and grabs it for each topic and creates a 2-pager on each topic so that you can see the prevalence from the data sources, you can see the goodness of fit in the population-based comparisons, and you can see the results from the chart review study, both for macroscope and non-macroscope records, all in one place. So the goal is that somebody who's trying to develop their own EHR system would look at our fact sheets and say, okay, I want to do obesity and I want to do diabetes, for example. And so they would just be able to grab the 2 fact sheets and look at our definitions, look at our metrics of validity, and make some decisions about how they're going to move forward with their system.
Are you guys hoping for a certain date of release, or just awaiting the publication of the article?
Yeah, the review process takes a long time. So, I'm hoping in the next 3 months that the paper would come out, but you never know.
Yeah, I think this is an excellent dissemination tool. I mean that a product that you guys have prepared. So I'm sure the audience will be definitely looking forward to its release.
Well, once the paper is published, the fact sheets will go up on the PHSSR website and also on the New York City Macroscope website. If anybody wants an advance copy, they could also email me, for their own use, but we can't obviously publish it until we publish our paper.
Understandable. So, with that, is there anything else, Tina, Sharon, that you'd like to add to the presentation before we sign off?
We really want to hear from other people who are doing this kind of work. So please reach out to us. Tell us what you're doing. Send us your questions. Propose collaborations. All of that would be great.
All right. Well, thank you so much, Tina and Sharon, for your presentation, and thank you so much, Sungwoo and Jenny, for your comments too as well, and for everyone with the Macroscope team at the New York City Department of Health and Mental Hygiene. We'd like to thank you so much for your excellent presentation and the discussion we've had for today. We'd like to remind everyone who attended today's webinar that today's webinar is available for download or will be archived at the Systems for Action website. And we'd also like to invite you to take a look and to join us for our upcoming webinars, beginning with a webinar that we'll be having in May 11 on cross-jurisdictional resource sharing and the scope and quality of public health services. So with that, we'd like to thank again everyone for joining us. We'd like to thank our presenters and our commentators, and we hope to see you soon again on these research and webinar progress series. So have a great day, everyone, and thank you for joining us. Goodbye.
Thank you.